Well, good morning again. I'm Dr. Bill Wyatt with the American Orthodontic Society, and I would like to talk to you this morning some about osteoporosis, its effect on orthodontics and especially on retention of orthodontic cases. I have a real interesting case here today that I want to discuss with you. It's let me see, I've got to get this thing going. It has a very strange effect on orthodontic patients. Now, this case came into me in 1980, and they had an orthodontic problem. It was not terribly severe, but severe enough. But the patient, this lady, did not return for treatment. But she did return back in 1985, and her orthodontic needs and problems had gotten much, much worse. And we think this is due, almost has to be due to her osteoporosis. And it had not been evident to me back in 1980, having too much, having these two models was a very good thing. I really learned a lot just studying these two models. And so I'm going to try to show that today with you. Here is the lady in 1980, and looked fairly normal. I didn't recognize or didn't think about the osteoporosis. Maybe that's my fault. Maybe we ought to check everybody we look at it when you get up into older patients, especially women. Not a great deal of facial change. This is 1985, but let's go through a lot of the other portions about this now. From the front, she looks fairly normal. There's no big problem. The facial structure's good. You can do orthodontics on this and help her a great deal. And here's her smile. That looks quite good, but she had several problems in there as I'll show you later on. And here's her smile in 1985. It had deteriorated quite a bit. Her two front teeth had tilted back a tremendous amount. Now, I don't know whether this the pressures of the mouth change, or whether I do know one thing: the pressure has a tremendous force on these teeth, and you have to really keep up with it in retention after you finish it. All right, here she is. This is I think this is 1985. Don't remember exactly. And another facial view. This is 1998, after we had treated her for several years here. From 85 to 98, it's about 14 years, something like that. And we had her in retention and were able to keep her teeth looking pretty decent, but we had to really stay with it. If she took her retainer out for just a short time, it would really go. Now, we let her sleep without it, but she had to wear it every day. Here are the models now in 1980, and this is not a bad orthodontic case. Just we've got a little deep bite problem over here, not serious. Not a whole lot of crowding in the upper anterior teeth. There's a good bit in the lower anterior teeth down here. Not a it's almost class 1. See if you can get this bicuspid to come down in here. This one's not that far off. The cuspid's not that bad. So from this side, she is not in a bad situation here. I'm going to erase those and we'll go to the next model. Now here in 1985, though, that was 1980, without anything going on other than this osteoporosis, we've got the class 2 is not too much worse, a little bit worse than it was, but as you get up to the front of the mouth, the change is tremendous. The centrals are going down like that, and the lower teeth are up in the roof of the mouth. It has really gone to pot. So I'm gonna, that's a Texas statement, they're gone to pot. But anyway, when I look at it from the front, here it is in 1980. This is not bad at all. But then when we go to 1985, the bite is closed completely right here. If I back that up, you see it was quite different then. So the bite has closed down tremendously in this length of time. Now we go back here. The lower teeth are hardly visible underneath here. The teeth have tilted back. I don't see how the roots aren't coming up against the tissue, right up against this area. Let's go to the next model now. This is 1985. Okay, over on this side, 1980. Not a bad situation at all. But in 1985, it has really deteriorated. I was astonished when she came in 1985, and I had these old records, and I went back and got her models out, and my gosh, I didn't see how this happened with nothing. She didn't have anything except the osteoporosis that I could lay this on to. So that's what I actually did, and she did have osteoporosis quite bad. We treated the case. Now looking at it from the top, you see some crowding up in here. Not a bad situation, but now in 1980, look at the difference in it. This is 85. 1985, these teeth came from, let's go back and just look at where they were and now where they went in 1985. Just 5 years lapsed in here. These came in too, if I remember. Yeah, they did. Yes, they did. Okay. Now we'll go to the lower model. The lowers in 1980 were fairly bad. In other words, they were crowded and the bite was deep. But in 1985, the crowding wasn't as bad, but they moved back, and then the bite got even deeper here. Okay, in 1980, looking at it from the front, they were up. This was in pretty bad shape, and she had a kind of a fistula down here with a little bit of drainage, which we had to work on. Let me go back on that again. And 1985, the problem here was a little worse, not too bad. In 1980, it wasn't evident. Okay, let's see. Now looking inside the mouth in 1980, this is just shot from the models, of course. The teeth were right up there close to the roof of the mouth even then, and they had crowded up some. In 1985 now, the teeth had gotten further up into the mouth, but had straightened up to some extent. That was kind of unusual. I guess if they go back, there's more room up there, and they could straighten up better. But this is a tremendous deep bite, and I thought this case was just going to take me forever to get it done. But we put braces on her in 1985, and I don't have a lot of pictures in between here, and the pictures I've got here were not the best. The focus is not too good, but you can see that these teeth had just totally straightened up here, and this is 1986, and the teeth just move so easily. I finished the lady in 11 months, and that's unheard of. I thought, well, this is just unreal. This had a bad pocket on here, and we had to keep it clean for her. But I put an intruding wire. You see, this wire went up and went underneath here, and this one just went all the way around with that. But I hooked it over and turned these teeth loose, and I just brought them down so easily. This intruding wire, of course, was down like this, and we brought it up and hooked it to the teeth, you see, and did not have this one hooked to it at the time. And then we just brought these teeth down by themselves and hooked them to that. The orthodontics just went off like clockwork. We were able to straighten those teeth up so quick, I just couldn't believe it. And there's the intruding wire again. The mechanics of it are pretty simple, and it's just this intruding wire in the auxiliary tube here. And I don't think I actually had my super duper little bend on that wire. You see, we just bent the wire down, but normally would come out of that tube, you see, with the wire, and then we'd have this bend like that, and now we would come down with that. And as you bring this up, this tightens this spring. You put it here, and this is really the way to make that. But in this case, I just brought the wire down itself. It was long enough there, brought it up, and it was trying to pull down, and it brought those teeth down, and with less force. You can put a lot more force on this, and it'll intrude or flatten out cases so much better. Anyway, it went off just real fast, and we were connected to the upper molars. We expanded the arch, got it all out and everything. The lower teeth straightened up, and then as we went on through, this is 1986, and there it was in 85, complete closed bite. You see, 1986, we had this lined up and put a retainer in there. She's got a crown on that tooth, and we watched this place down here, kept cleaning it out and taking care of it, and it finally healed up and got better. Now this lady brushes the heck out of her teeth. She really tries to take care of them, and they're lined up good now. But brother, you leave this retainer out for just several days and you've got a problem. You're getting it back in again, see. So we had to keep wearing that thing. We wear it all day and then into the evening, but we took it out at night and let her gums have a little rest. It's a wraparound retainer, and these teeth come into occlusion, I mean really good. And if you're trying to put retainers in, this is the best type of retainer. You let the teeth come together and they function against each other and they wear in and everything. If you run these stupid wires underneath here or behind the cuspids and come up with these deals and put clasp on them and run them under the teeth, then they come down and bump those wires. And when they're wearing a retainer, the teeth run one way and take it out to go the other. Now, if you went in there and ground out the teeth where the wire doesn't come in contact at all, you might could get them to work with those clasp and this wire going out under there. But it's much better to just make a wraparound retainer, and you can put little dobs of tiny composite under if you think they're coming out or something. They stay in super well. You just have to believe me until you try them. And I would use nothing but wraparound retainers. Now we bonded a retainer on the bottom arch. Now this is 1985. And you can see the model's in pretty bad shape there. I mean, the teeth are in pretty bad shape. Here we are in 1986. I mean, we had this lady finished. And so we took her out of the braces and put her in the retainer. I think it took about 11 months. We probably could have done it even quicker, but the teeth just move like mad. And she's got some the spots in here. She brushes and got kind of wear. You'd have to fill in those teeth for her. But her osteoporosis was pretty bad. I'm going to show you here 1998, I believe, something like that. We've got some models on her. And I'm going to show you. Here it is, 1985, 1986. Okay, 1985. And there's looking at the retainer in the top. Now we've had this retainer and it wraps around everything she's got in here. And I put a bite plate where those lower teeth that used to be up in the roof of the mouth come up against this groove right here. And they fit in there like a glove. And you wear that thing. Now she also has a lower bonded retainer, which you have to retaining cases with osteoporosis. In other words, older ladies have more osteoporosis than men do. But in making a teeth, this retainer is like a horseshoe. She has to wear it all the time. You have to run this inside wire way on up in here. Bring this one up in here and actually can almost lap them. But if you don't, the retainer is real thin in places like this, and it can break pretty easy. So you want to run your heavy 036 wire that you come around and it's bonded or soldered over here on this side. But no clasp across any of them. I never use those. That is the best retention. These teeth are free to erupt with the other teeth below, and they fit in together and help hold each other in place. All right, here's the lower arch, 1985. There's the lower arch in 1986. And we bonded it very heavily. In fact, I wouldn't mind if going back again if you ran this wire around on the first bicuspid, but it's a heavy wire and it's bonded to these teeth. Now back in when we get to 1998, this is the teeth. You hit something and it'll crack this bonding material off the wire, but the wire's in a groove on the teeth and they stay in place. So that's something you might want to think about in your retention of your lower cases. Now you have to keep these clean with stimulants or something that you can run between the teeth, or little brushes and things that take care of them like that. But they've got to be bonded like this for the rest of her life. And we did. We kept them there. Now, I failed to cover up her name, but the lady passed away. Now, this is 1998. The date is covered up down here, but you notice we got this cleared up down below, and it's working good. And I guess we cleaned them a little bit before we took these pictures. But this is 98, and that was 86 back there. And our teeth are staying, but brother, we had to stay with them. And that's a frontal view. And she was a very nice lady, and I failed to cover her name up. She's been dead a long time now. So, but was a very fine woman, and I was glad to be able to help her and bring these teeth out, and she at least spent the rest of her life with a nice set of teeth. Looking up above, 1998, we got a little bit of relapse in here. Those teeth are trying to go back. They were way up and tilted back like that. But if you're dealing with these people with osteoporosis, men or women, I don't know, very few young people have it, but you really have to stay with the retention of these cases the rest of their lives, because boy, you take that thing out, just a few days those teeth move like mad. So that's something that I wanted to bring on. But I wanted to show you this lower 3-3 retainer. The bonds held on the cuspids real good, but where the bonding material went over the arch wire, you see, right here, this tooth, you hit something with a tooth and it'll pop the stuff off there, but then the wire is lying right there in a deep groove in that material, and it still holds it in place. This tooth has moved some in 98, but not much. And it'd be difficult to take this whole thing off and redo it because of that. That will hold that tooth there. It can't go up or down. It's in the wire set and the acrylic is up like this with the bonding material. It was over it, but it popped that off. You'll hit something with this tooth and it'll move it forward and pop that bonding material off. But the tooth is the acrylic bonding material is still around the wire back here, and so the wire's fitting in a groove. So if you have this type of case, bond every tooth on there, and it's better with a stiff wire in this case rather than a flexible wire. That may be questionable. Maybe if you had a flexible wire, when the tooth moves a little bit, it would still hold on to the wire. But you really got to bond everything down on the bottom together. Okay, let me go over here. Now this place in 1986 was pretty bad, but in 1998, so that's about 12 years, something like that, but that healed up and that stayed. Now one thing that helped this, that tooth moved some. It was had very poor bone. The osteoporosis on the bone, of course, these teeth could be moved all over the place. So these are all bonded together. That this one broke loose, and those may have broken, but they're still in the little groove. So the tooth stayed pretty much like it is. This is 12 years after we got out of treatment. But brother, you had to stay with the retention. And there's a close-up of the bond in 1986. And I don't think I have. Yeah, I do. Okay, all of them have broken loose, but they're staying in place. And boy, this stayed on the cuspid teeth. That pad stayed there. And there that lower is in 1998. And this is the lady after we finished. This was an interesting case, and this is something it would be good to learn if you do a lot of adult orthodontics. If you get into someone with osteoporosis, this one relapsed like mad, just with nothing but just her own natural force really messed up her teeth. So I'm going to hush now, and we will stop this video. And I hope you get something out of this, but that was an interesting thing. And so we'll stop now. Thank you for watching.